Now we are going to start immunological blood transfusion reactions. Why the people need blood transfusion? It is needed for the variety of reasons, primarily due to blood loss in blood disorder. Common situations include the major cell traits where trauma from the accidents, complication during childbirth, and certain medical conditions like anemia, sickle cell disease, or thalassemia. Additionally, some cancer patients and individuals undergoing organ transplant may require transfusions. But during that transfusion, there may be blood transfusion reaction occurs. When the recipient immune system react to the transfused blood typically due to blood type incompatibility or presence of antibodies against the component of donor blood. So first we are going to our first type, that is allergic anaphylactic reaction. The allergic anaphylactic reaction, the type 1 hypersensitivity against the plasma protein that is transfused blood. It is a type 1 hypersensitivity, and you know the type 1 hypersensitivity is occur within the minutes or maximum 2 to 3 hours due to release of preformed inflammatory mediators in degranulating mast cells. And the most common allergen due to an anaphylactic or allergic reaction happening in the blood transfusion is due to IgA. So IgA deficient individuals should receive the blood product without IgA, because IgA is the very most common allergen that causes this type of reactions. And the clinical presentations are pruritus, urticaria, anaphylactic, are wheezing, hypotension, respiratory arrest, and a shock. And if you guys focus on this diagram, the donor blood having the plasma protein including IgA that will going and combine with that, and there will be anti-IgA receptors, and that will be make the degranulation of mast cells, and histamine and tryptase will be less. Now we are going to study about acute hemolytic transfusion. It is a type 2 hypersensitivity reaction, and it's most commonly called intravascular hemolysis due to ABO blood group incompatibility. It may cause a EV extravascular hemolysis due to host antibody against donor RBCs. And it happened during the transfusion within the 24 hours due to preformed antibodies. And presentation include the fever, hypertension, tachypnea, tachycardia, flank pain, hemoglobinuria. That if it will be intravascular hemolysis, if the extravascular hemolysis, then there will be jaundice. Like they're having the RBCs, the donor RBC with the A and the B antigens, and they the host anti-A or anti-B antibodies are there. They will be caustic and through the destruction of RBC, and it will cause hemoglobinuria or jaundice. Now we are going to the febrile non-hemolytic transfusion reaction. It is type 2 hypersensitivity reaction having host antibodies that will act against the donor HLAs and WBCs. Like in this, there will be immune system going to act against the antigens present on donor RBCs, here against the plasma proteins, and in febrile non-hemolytic transfusion, it is a reaction against the donor's HLA and WBCs. And it will give the presentation of fever, headaches, chills, flushing, and more common in children. And it will be happen within the 1 to 6 hours due to preformed cytokines. And cytokine created by the donor and WBCs accumulate during the storage of blood products, and reaction prevented by induction of blood products. Same like that in allergic and anaphylactic reaction, we are giving the blood product without IgA. Same like that for the febrile non-hemolytic transfusion reaction, we are going to do the co-reduction of blood products. The second, we are going to do the transfusion-related lung injury. You are giving the blood, case of blood transfusion happening in the one patient, and suddenly you get roar type, crackers type voice in the lungs during the auscultation, then it will be happening. It is maybe due to ARDS, acute respiratory distress, non-cardiogenic pulmonary edema, or due to blood transfusion. It will happen to the donor antibody against the host. What is going to happen? There is donor anti-leukocyte antibodies. In febrile, there was antibody against HLA and WZ, but in transfusion related acute lung injury, we having donor anti-leukocyte antibody that will go and attack on host neutrophils and endothelial cells. This will cause the respiratory distress and non-cardiogenic pulmonary edema. There are two hit mechanisms. One is neutrophils are sculptured and primed in the pulmonary vascula due to the receptor and these factors. For the escaping mechanism, the neutrophils go into the lungs to protect themselves from the anti-leukocyte antibody. And neutrophils are activated by the product like anti-leukocyte antibody in the transfused blood and release inflammatory mediators that will increase the capillary permeability and cause a pulmonary edema. It is also happening within minutes to 6 hours. Now we are going to our next type, that is delayed hemolytic transfusion reaction. It's an onset over the 24 hours because it's a delayed hemolytic transfusion and maybe sometimes clinically silent, having the mild fever and hyperbilirubinemia. And it's a generally self-limited because it is an anamnestic response of foreign antigen on the donor RBCs like RHD or other minor blood groups and previously encountered by recipient typically cause extravascular hemolysis. And it's happening like if there's any preformed, any antibodies are present to against any antigen that is already experienced by in the host body, then it will be occur. And it will cause in the extravascular hemolysis. But the main difference between the extravascular and intravascular hemolysis? Basically, there is a difference between the location. Extravascular hemolysis happens primarily in spleen and liver, where macrophages engulf and destroy all the damaged red blood cells. Intravascular hemolysis, on the other hand, involves the destruction of red blood cells directly in blood vessels. It's all about immunological blood transfusion reaction, but don't forget in allergic anaphylactic reaction, the most commonly we are giving the blood without IgA in IgA deficient individuals. In acute hemolytic transfusion reactions, there is intravascular hemolysis typically due to ABO incompatibility. In febrile non-hemolytic transfusion, there will be antibody against the HLA and WBCs of host. In transfusion-related acute injury, there is a donor leukocyte antibody that will attack on host neutrophils and endothelial cells. And in delayed hemolytic transfusion reaction, there is a response to foreign antigen on donor RBCs. Now we are going to start about autoantibodies that are just buzzwords to diagnose the disease, and that is just an association to get and catch the disease and get our answer on the exam day very fastly. For that, you have to recognize, you have to remember or learn about 2 to 3 days before going for your exam, or also before anything you have to go through. From that, all the autoantibodies is a very important association. For example, first antibody is anti-postsynaptic. It's a type choline receptor that is associated with the myasthenia gravis, and anti-presynaptic voltage-gated calcium channels that is associated with Lambert-Eaton myasthenic syndrome. In both diseases, there will be decrease in muscle tone or weakness, lethargic, but maybe the clinical presentation may be same. But most of the thing that mostly the important thing that's going to differentiate both diseases is about the autoantibodies. In myasthenia gravis, the autoantibodies are formed against the acetylcholine receptor that was present on prosynaptic Now, under Lambert-Eaton myasthenic syndrome, there will be autoantibodies against the vaulted calcium channels present presynaptic site. Next, we are having the anti-beta 2 glycoprotein 1 that is related to antiphospholipid syndrome. Recurrent abortion in a female, maybe you heard, it is just like that. Antinuclear ENA is a non-specific screening antibody often associated with SLE. Is the anticardiolipin, lupus, anticoagulant, or I should say SLE and antiphospholipid syndrome. Is the anti-double-stranded DNA and anti-Smith that are associated with SLE 100%. Is the anti-strong that can drug-induced lupus. Whenever you guys are watch anti-histamine antibodies present in MCQ, just mark the question drug-induced lupus. Anti-U1 RNP ribonucleoproteins, that is a mixed connective tissue disease, these all are same. But they having for the subtype rheumatoid factors like IgM antibody against the IgFC regions or anticyclic citrullinated peptides are more specific anti-CCP that all are associated with rheumatoid arthritis. There is anti-Ro or SSC or SSP that is certainly associated with DiGeorge syndrome. Anti-SCN 70 is going to scleroderma. There is already SCL already they mentioned in the antibody that is starting point of scleroderma. With the anti-cell will concentrate limited scleroderma or stress syndrome. Anti-synthesis or anti-SRP with the polymyositis, dermatomyositis, anti-mitochondrial, primary biliary cholangitis, the most common cause of infants, liver disease or liver cirrhosis. Anti-smooth muscle, anti-liver kidney, microsomal 1, autoimmune hepatitis. Myeloperoxidase, anti-neutrophilic cytoplasmic antibodies that are already microscopic and eosinophilic toxic cholangitis and ulcerative colitis and primary sclerosing cholangitis is 1 ANCA and P-ANCA. They are the most common autoantibodies and related many diseases. You are having a C-ANCA that will only having the glomerulitis, pancreatitis, and antiphospholipid A2 with a primary membranous nephropathy, anti-Hemmings dysmosome, the Burroughs phagoid, and anti-dysmoglein with the famigis allies. We have anti-thyroglobin and anti-thyroid peroxidase, with Hashimoto thyroiditis, and anti-TTG. Except they will do the sleep disease and IgA anti-endomyosial or IgA anti-tissue transcriptase or IgA ITG deaminated glycogen peptides are going to cause celiac disease. acids and decarboxylate easily cell cytoplasmic or antibodies, type 1 diabetes, 1 diabetes. Antipruritic cells are anti-intrinsic cause of precaution anemia and anti-glomerular based on membrane going to cause good stress syndrome. In innate immunity defect, in innate immunity defect, for example, we are having the disorders of leukocyte antigen deficiency, antigen deficiency, there's a genetic hemorrhaging, genetic hemorrhaging syndrome, also chronic glomerular disease. For that, if we talk about the important points in liquid antigen deficiency, there will be decrease in neutrophils migration. Neutrophils migration. And if you talk about the genetic hemorrhage syndrome, there will be transfusion impaired. And if you talk about the chronic dermatitis disease, there will be decrease in respiratory bursts, and also there will be recurrent infection of catalase positive. Now we are going to start about the immunodeficiencies. In immunodeficiency, a general principle is there is a low T cells and loss of T cells and B cells, granulocytes or complement. In having the acquired HIV or chemotherapy, They usually present in infancy with a recurring infection. So first we are going to talk about B cell disorder. And B cell disorders include first S-linked agammaglobulinemia, answered proton. Protons agammaglobulinemia. It's a defect in the BT tyrosine kinase gene. There is no B cell mature X excessive. Is in why it more prevalent in the books. Presentations are recurrent bacterial interviral infection after the 6 months due to decrease in maternal immunoglobulin G that is given from the placenta. If the baby is going with the breast milk, they will be in IgA. So again, we are going with the X-linked agammaglobulinemia. It's an X-linked failure of B cell precursor to become B cells. It having a light they not produce effect in proton kinase gene. Their symptoms from the 6 months of age and loss of maternal due to loss of maternal antibodies that are IgG. In the protons agammaglobulinemia, there is a recurrent respiratory bacterial infection, the loss of opsonization by the antibodies like H influ H-flu, strep pneumonia, are more common. Loss of opsonization. In classical presentation is due with recurrent otitis media or cyanic test or PNA. With a GI pathogen infection that happen in GI, it is happening inside It is at loss of IgA. What is going to produce that Peyer's patches? And its most common organisms are enteroviruses like Popol and Coxsackie and Giardia that are GI parasites. The key findings are key findings of X-linked protein ichnoria is they having to mature B cells. We having such surfaces 1920 BCR. They are absent in peripheral gut, and they are the germinal centers of lymph. You guys know the B cells are going to mature developing germinal centers. The germinal center also and the twelve. There is an absence of antibodies of all classes, and for that we are going to treatment